Kia ora and welcome. Look, it's a real pleasure to be hosting this meeting in conjunction with ACC on the major changes that have actually occurred in terms of ACC's coverage, and that's maternal birth injury cover. I know this has been a huge piece of work for ACC, launched just recently, and really this seminar is really to explain and talk about the changes that have happened in the legislation, and I suppose the implications of that for general practice and general practitioners. So it's a real pleasure to be here. So I'm Brian Betty, I'm Medical Director of the Royal New Zealand College of General Practitioners. I hope by the end of this seminar we'll be a lot more familiar with maternal birth injury changes that are occurring and how it affects our practice. Just a couple of housekeeping things before I introduce our panel. Look, this is CME endorsed. And there'll be key presentations as we go through different aspects of these changes. Now, everyone will be put on mute. Certainly there's the opportunity to ask questions through the chat function, because at the end of the session we'll have a Q&A question and answer session to hopefully answer your chats. If you do want to have MOPS points accredited for this session, please go through the chat function and address it to the Stakeholder Engagement Coordinator and put your New Zealand Medical Council number. And we are recording the session, so this can be distributed and viewed by different practitioners who may not be here at this point. So look, we've got a really good panel today to discuss the issues around the changes. Dilki Rosaya is a vocational registered medical administration and ACC strategic clinical advice and government team lead. Dr. Peter Burke is a vocational registered GP and a professional practice fellow with the University of Otago and clinical advice manager with ACC. Sean Westhead is a registered physiotherapist, and he is the product owner, as they call it, for Maternal Birth Injuries Initiative at ACC. Alan Furness is a vocationally registered GP and a rural generalist obstetrician. Nick Walker is a consultant obstetrician and gynecologist, and Dr. Melissa Davidson is a specialist pelvic health physiotherapist. I'll have to actually leave possibly before the end of the seminar, and Sean has quite kindly offered to close off the session with a question and answer session at the end. So at this point, I'm going to hand over to Sean to lead us off with Karakia and then to start the first part of this seminar.
Kia ora, Brian. Thanks very much. So just going to lead you through a Karakia. So whaia, whaia, whaia te tika, whaia te pono, whaia te aroha. Mō te oranga tangata, kia puta ki te whaia au, ki te o marama. Homie, huie, tai kie. So striving to do what is right, understanding to act justly, being considerate of everyone, that it may improve the lives of all. And I think that's really quite a fitting start to this piece of work, which we've been working on over the last 6 months at ACC. It has been a piece that is going to be impacting and improving the lives of many people and their whānau, assisting them in the recovery of maternal birth injuries. So this piece of legislation, or this change in the legislation, started or took effect on the 1st of October this year. And what it was a change in the definition of what is included in an accident. So we now consider an accident to also include an internally generated force from the onset of labour to delivery of a baby, and also will accept a maternal birth injury that is listed on Schedule 3A. So that we've got a list of primary injuries which we can accept, but as well as those primary injuries, if we have a consequential injury or a complication secondary to one of those primary injuries, those are also things that can be considered by ACC for coverage. And for that list, it was considered comprehensive by many of the experts that had a look in at the select committee process. But I suppose we will review, and the government has put provisions in to ensure that list is reviewed 3 years from when it went live. I guess a couple of other important things is that it is maternal birth injuries, so we don't cover injuries to the child, to the pepe during the birthing process. And there was a start date for this piece of legislation. So injuries from the 1st of October this year going forward are able to be covered under the change, but existing injuries unfortunately aren't. I guess for those two last points there, we do still have our treatment injury legislation, and so if the person had sustained an injury prior to the 1st of October, that could be put down to the provision of treatment, then those may be able to be considered under that part of the Act. And so I suppose that's a really important thing to just think about. Here's a list of those 12 injuries. I guess I won't run through them, but just so you can all see, most of these things you may see in your primary care setting, even if it isn't as an acute presentation. So people who have these injuries will probably cross your path in general practice at some point if they need extra support for their injury. I'll hand this one over to Dilky.
Thanks, Sean. So getting to sort of the core matters here, the first thing, sort of the what you need to know that we really wanted to share up front. So reiterating what Sean said, so the legislation came into being 1st of October this year. So that means that the birth that may have incurred the injury on that list has to have occurred on the 1st of October or going forward. There was consideration about the period before, and the legislation as it stands is from the 1st forward. So that was the first thing to reiterate. And then just to be clear, I think it's, it's stating obviously what you know, but this is about funding support, entitlement services that we're able to fund. Clearly the clinical care carries on as you've always done, and clearly obviously a priority, doesn't need to be said. This is about ACC's ability to now, for an accepted claim, provide the supports, the funding, the access to some of the services for your patients. And then the last thing was just on the slide, just a point of interest. Obviously 1 October wasn't that long ago, so not surprisingly, the claims that we're seeing coming through are almost completely all, if not all, coming through the hospital system so far. But we're expecting, obviously, with time that's going to change, and that you all will be starting to lodge claims in general practice and in primary care settings with time as well. Next slide, please, Sean. So a piece of work ACC did at the start of this obviously was a new area for us, and there was various things we needed to consider, but what turned out to be a very important and sort of insightful piece of work was some qualitative research with birthing parents who had given birth over the last few years and had a number of those diagnoses on the list, and really hearing from them what their experience had been like. There's a lot of information, a lot of themes in there that we were able to take away and use as we looked at the services that we would be funding and how this would all look. But two pieces of, or two themes that we thought really worth sharing given the audience this evening are on the slide. So the first one was, in many cases, and for many reasons, and you'll know them better than I do, and they're on the slide there. What we were hearing was it took the injured parents a long time before they were able to get medical attention to support their recovery. So that was one theme we did hear. And another one was the 6-week check, that most of the parents that we spoke to experienced the 6-week check as baby focused rather than an opportunity to talk about their own health. Completely understand why that is needed, and there's a lot required at that 6-week check, but I guess we just wanted to highlight, particularly now with that opportunity to have one of these injuries covered, that may well prove to be an opportunity for that conversation with the mum at that 6-week check as well. I think I'm handing over, Sean, to Pete.
Kia ora koutou. So one of the things we're particularly proud of is the platform on our website around understanding maternal birth injuries, and there are the URL that's coming up in a slide in the next few slides will get you to maternal birth injuries on our website. and that'll give you the opportunity to get 3 different key bits of data. The first one here is around for healthcare providers, and it covers through in two pages, essentially what all of those covered injuries are that we have, who can lodge them, and some key examples of read codes that you can use. So that's the first thing. Next slide, please. And this is that opening page that gets you there. And depending on, you can click on each one of those and it'll get you to a page that goes through how to lodge a maternal birth injury. Sean's going to mention a bit of that in a couple of slides' time. The one that's particularly really useful, and if we go, is the one on the far right, which is the information for parents and whānau. Next slide, please. Yeah, and so this is collapsed into one page, but essentially it opens up and gives you a whole lot of different resources that you can find out what's normal after delivery, and all the things that are abnormal that you may potentially want to come and see somebody about to get care or be referred on to an appropriate person. So this is new, so please, in terms of you all have your own way you share information with your patients, be it websites, be it your clinical staff within your practice or whomever, but please go and have a play around on those 3 parts to this slide. It'll only take you 5 minutes and it's incredibly valuable. So as a former GP of a long time, I think this information, I'm particularly proud of what we've produced here, so I'd encourage you all to have a look. Thank you.
So thanks, Pete. And I guess this is one of the places where ACC's involvement really is in how things happen. This is a form that's familiar to many, or if not all of you. Maybe not in this form, maybe in your practice management software system, but there's a few really important things for this particular change. So the date of injury is the date of birth of the child. And so that's just makes it really sort of easy to decide when a particular accident has happened. The other thing is where the quick guide that Pete had run through a little bit earlier, a couple of slides back, has that list of codes which can be used as putting forward the diagnosis for ACC to consider. And there's this little bit here where you can see the 3 letters MBI, could be maternal birth injuries, but essentially if you put the right code in off the list and you put in maternal birth injuries, what that will prompt our internal system to do is send this claim to the right place, and it will mean that people's claims and services can get processed a lot more quickly. And reduce any of the sort of wait times and things that may be experienced for those people if that's done well. So just, I guess, just a real prompt, and so just to check out the quick guide and to really make sure that if you are filling in claims for these clients, that you look at just making sure you get that part right. Back to you, Peter.
So we've asked some of our external advisory group along to the session, and so we've just asked them, and they'll be later in this presentation preparing their kind of key take-home messages. But one of them was that patients can access pelvic host physiotherapy, and it can be a good first step for most of the presenting conditions. And if you've got persisting or puzzling symptoms, then ACC can support you to see a gynecologist or other relevant discipline.
So we've done a few sessions for different audiences, and so we've gathered up here on this slide some of the questions that have come through before, so that we've assumed you might be thinking the same thing. So I'll just run through what we were asked before and the responses. So just to reiterate, injuries from birth, so prior to the 1st of October, they're not covered, unless, of course, they are a treatment injury, which is the previous legislation that continues to apply, that hasn't changed at all. We've had a question around unattended or home birth. So again, of course, if there was a tear evident later, at some later time it's diagnosed post-birth, then if it's on the list, absolutely, that situation does attract cover. Claims can be made at any time after a birth. I think there's sometimes a bit of a misunderstanding around the 12 months. There is no 12-month rule. So claim can be made at any time after birth, and it does not have to be in the first 12 months. It can be after the first 12 months as well. Regards mental injury or psychological support, there is the potential that you would have seen that there's no specific mental injury on that list, and that is because what we'd be looking at is what technically is called a consequential injury. So you'd have the physical injury, that would be one of the injuries on the list, and then if there is a mental health consequence of that, then absolutely that condition could attract ACC cover and support that way. But equally, if there's a physical injury that someone's requiring psychological support with, that isn't actually a mental health diagnosis, there is potential to get support that way as well. In terms of adding additional diagnoses, it's the methods you're already aware of. So the ACC 32 or the ACC 18, just like you use for adding a physical injury, additional diagnosis as well. So no change there. Just a couple of points on episiotomies. So they are not defined as a covered injury. However, if there's an extension of an episiotomy that results in a worse, third or fourth degree tear, then absolutely that would get cover. And then everything that applied to episiotomies previously around the potential for treatment injury, if something goes wrong around the episiotomy per se, there's the potential for treatment injury cover. That'll obviously have to be assessed, but that avenue remains unchanged. Thanks.
Thanks, Dilke. I suppose this is a really important slide as well. It just reiterates a few things that we've spoken about in the lead up. But if you need to contact us about anything regarding maternal birth injuries, please use the pathways that you used to. So we've got our provider help line, the phone number there, and their email. If it's regarding something you'd normally deal with a person like an ACC engagement performance manager, please contact your local contact for that. You can look on our website. So we've got both the area for our health professionals and our birthing parents. So both of those links there. And I guess the other thing is the ACC is set up to support clients who are injured through funding for services. If there's a concern around the clinical care that's been provided, that's more or should be directed to the Health and Disability Commissioner rather than to ACC. They're set up to deal with those sorts of issues. What we'd like to do now is have a look back through the chat, talk about some of the questions and pātai that have been raised, and also hear from the members of our external advisory group. So what I think I might do first of all is hand over to Alan. He may have a few things he'd like to discuss, and then we'll go to Melissa and then Nick. So over to you, Alan.
Thank you, Sean. I'm Alan. I'm a real generalist. I'm not a specialist. I'm a vocationally registered GP that does procedural obstetrics for the last 30 years. Currently working on the West Coast, representing the RNZCGP at this MBI Maternal Birth Injury Forum for the last few months. That's how I get to where I am. I make a huge plug for general practice primary care. I think this is the exact profile of good care that we expect these patients to be falling into, as the midwifery care seems to be tending to tailor off after the women have been involved with their confinements. They're going to precipitate back into primary care, and there we need this ongoing awareness of these patients presenting with problems. And it's opportunistic for most, We've got to make the opportunity at immunizations, at child who might be unwell, to actually incorporate mom into the discussions and just quickly pose a few questions which are relevant to her health, her breastfeeding, her, etc., and specifically allude to where we're sitting with the potential for her to have had experienced a maternal birth injury. As we all know, most of them occur acutely and are dealt with acutely in the labor ward and in theatre thereafter. But there are those that then continue to be complications thereafter. We're really leaning on our primary care and their supporting staff, all those good nurses, practice nurses, etc., who are part of that team, to ask the questions, because if we don't ask the questions, we're not going to get the answers. Unfortunately, specifically in sub-Saharan Africa, the subcontinent, and our women of the Pacific Rim, this is culturally reticent to present with these problems. It needs to, and preferably women doctors, women nurses have better purchase with eliciting these things from women, but it needs us to ask the questions. Unfortunately, there's a certain amount, as I say, reticence of some of these patients, and even some sort of cultural acceptance that birth injuries are just part and parcel of being a mum. And we've got to take and dismantle that down and make them aware that these things should be treated and ongoingly reflected on where that avenue is going. So we need to ask the questions. I think that's the most important thing I'm plugging for, is to see my colleagues who I know who do the rotator cuff injuries, the low back injuries, the knee derangement injuries. You get onto them and you work them up and you refer them on. This is one of those things we need to also just make ourselves available onwards. And I'm sure most of our colleagues are doing this well to date as well. Precipitous labors, previous tears, lengthy labors with assisted deliveries. These are all the sort of machinations of precipitating injuries that we need to tease out quickly. And what I really appreciate is Melissa, who you'll hear from in the next few minutes, who's a pelvic floor specialist, who's offered, and hope we get there, to put together some sort of scoring chart, which is very, very simple, of questions that we can, in private practice to primary care, can put in the laps of these women to quickly tick box how they're performing with their urinary incontinence, bowel incontinence, pain, dyspareunia, etc., that we can identify these women expeditiously and refer them onwards to the care they deserve. Having a chat in the Christchurch environment, just a point of concern from our side as what Christchurch Obs and Gynae department, and we hear, interesting to hear what Nick has to say on this, representing the Auckland environment, but this will become an ACC-driven referral if women are being identified with pelvic floor injuries. Some of this will then obviously be taken away from the gynae and obs departments of our tertiary units, and there's a concern that some of these specialists in training are going to see a lot less of these injuries. They're going to go to the private practitioners a lot quicker than what they're going to land up in the zones of the tertiary training unit. So we just have to be aware that how we training onwards our next layer of ONG specialists, and I'll be interested to hear what Nick says with that, in becoming au fait with the treatment and ongoing treatment of these injuries. But really grateful to have been part of that working group. It's been an absolute pleasure to be involved with some really passionate people who are motivating for expeditious and good care of these women who, as I say, deserve really, really good prompt diagnosis and management and ongoing surveillance. Thank you.
Thanks, Alan, and thanks for coming along and sort of supporting us with the messaging out to the sector. So what I might do is hand over to Melissa, who is our pelvic health specialist, physiotherapist, and she also had a slide. Do you want me to pop that slide up for you now?
Yes, thanks, Sean. So welcome, everybody. As they've said, I'm a physiotherapy specialist in pelvic health. That's what I do all day, every day. And why these injuries are common, it is not normal and they are treatable. As Alan has said, 9 out of 10 patients in your waiting room will not declare to you that they are having pelvic health problems, and yet they are. So they will only sort of tell you if you ask them. And we see this all the time in private practice and in the hospital. So the current screening questions that I would recommend that you put into your consent forms, simple tick boxes. Do you have any incontinence? Now that covers off urinary and fecal. So just, do you have any incontinence? Do you have any heaviness or dragging sensation in the pelvic region? That is again looking for pelvic organ prolapse. Simple question. And the other question you can ask, have you noticed any changes in your ability to have intimate relations with your significant other, or wording to that effect? We used to say, do you have any sexual dysfunction? But people would never tick that. But if there's been changes postpartum, then they're treatable and they don't have to put up with pain and discomfort. So those 3 questions you could put into your consent forms, just like you ask for, do they have a pacemaker? Are they a smoker, etc. So they're simple questions, easy to implement. And when women are asked them, they are very pleased to get asked them, as long as it's done in a respectful way. And they know why you're asking, that we're just making sure that you are realizing these might be common, but it's not normal and they are treatable. Now in the chat function, I've put the link to the reference to pelvic floor questionnaire. So Australian pelvic floor questionnaire is something that covers off incontinence, prolapse, pain, and prolapse, pain, sexual function. Not pain, sorry. Prolapse, urinary function, urinary, bowel, prolapse, and sexual function. Simple, takes them about 3 minutes to fill out. It's a tick box and you can get a score from that and then you can track them. So we're suggesting that our pelvic health physios around New Zealand use this as a really good outcome measure to see how things are changing. And it's also a good way of opening up to patients to go, okay, it's simple, it's a quick box, takes less than 5 minutes, they can fill it out online if they wish to. It's easy enough to put it into your systems. Finding a pelvic health physio. So you want to make sure that you're referring to pelvic health physiotherapists, not standard musculoskeletal physios. If there's a coccyx injury, yes, they can see this musculoskeletal injury, patient physios, but if there's a coccyx injury and that coccyx needs to be mobilized, it's got to be done via rectal mobilization, where you've got to be able to grab it. And that is a pelvic health physio. The same for prolapse, incontinence, sexual dysfunction, you need to be a pelvic health physio. So as the slide says, ACC can't endorse any specific option. There are various directories available. On Physiotherapy New Zealand, there is a filter that is filtered for pelvic, women's and men's health. However, they don't require any physios to prove that they are doing internal examinations. So just be aware that may not filter you down to just pelvic health physios. Continence New Zealand website has a list of people who deal with continence issues, also prolapse issues usually. Those are a list of pelvic health physios, which normally are doing regular internal examinations. And disclosure here, I run a pelvic health directory, which is, I basically check every single person on that directory to make sure they are doing qualified to do internal examinations, which is what you need to be doing for it to be a pelvic health physio. There are different names on each one. They do differ between them. It just depends. A really good way of figuring out who's your local person is talk to the local physios in the area, talk to the midwives who may know them, talk to your nurses who may know them. So just talk to whoever's in the area to figure out who is a pelvic health pelvic health physiotherapist. Failing that, get hold of me. And I will be able to send you hopefully in the right direction. And I will put my contact details in the chat function. I think that's about all that I really wanted to get across. So back to you, Sean.
Thanks, Melissa. I'm just going to stop sharing that screen, and absolutely right with that, talking with your local physiotherapists. Having learnt a lot about maternal birth injuries over the last 6 months and being a physiotherapist, I would still hand you on to someone well more qualified than myself to do any of that work. And so I think that's a really good option, especially in your local network. So thanks for that. And finally, we've got Dr. Nick Walker with us, specialist obstetrician gynecologist. So welcome, Nick, and I'll let you take the floor.
Kia ora, Sean, tēnā koutou katoa, nau mai haere mai ki te hui o te rorohiko i tēnei ahi. Ko Nicholas Walker tuku ingo no whakatohe rao ko Ngāti Parau Ahau. My name is Nicholas Walker. I'm an obstetrician gynecologist practicing in Auckland, as Alan has been alluding to. And I was part of the external advisory group working on this maternal birthing injuries project. I'm really excited to see what's been achieved behind the scenes and happy to share that some of with you tonight. I thought I'd just talk about what I can see the strengths of this program are. It's behind the presenting complaints, a wide range of therapies across all subspecialties are available to the patients according to the ACC pathways. As has been said, pelvic health physiotherapist specialists are a big part of that. But also there's the option to refer to urology, general surgery, even gynecology and the subspecialty of urogynecology. Rongo Māori is included, as well as psychological and mental health assessments. As Dilke also mentioned, there can be secondary consequential matters to make people more holistically well. And another key is the breadth and depth of the ability of the types of injuries that can be claimed. You can go back and look on the slide, but there really wasn't, as far as I can see, any maternal birthing type injuries that have been left off the list. Full credit also to Dr. Jackie Smaldridge and Dr. Louise Tomlinson. They are urogynecologists who do a lot of pelvic floor surgery. They were colleagues of mine also involved in the group. I also represented Te Ora, the Māori Medical Practitioners Association, on the advisory committee. I thought I'd comment a little bit, not to be negative, on some of the weaknesses of the system. Really, the only weakness I can say is it's actually yet to be tested and therefore determined. It's a sort of a new thing. It's brand new, ground up as far as I can see, rebuild of a new idea that women's or birthing parents' injuries ought to be covered. I think we should acknowledge the hard work done by the parliamentarians and, of course, the constituencies of birthing parents who have recognised the decades and decades, and you could even say centuries-long need that birthing injuries can really be significant in affecting the lives of those people from the birth onwards. And any of us working in the maternity system have seen many cases of women, birthing parents indeed, who will greatly benefit from the 1st of October onwards. Another weakness has been mentioned by Sean and Dilke, doesn't apply retrospectively, but that's obviously up for history to have changed from this point, 1st of October onwards. So I think the answer to these weaknesses are to have patience in using the system, patience with your patients, and I'm sure ACC will have a feedback system that allows users to say what's good and what's not working about the system going through. In terms of referral information that general practitioners might be expected to provide, about 5% of births in Aotearoa are home births. About 95% therefore will occur in some kind of maternity facility. You'll have noted home birth injuries are still covered, which is excellent for those 5%. For maternity facility births, I don't think your referrals will need to have much information about what happened at the birth. That most maternity facilities in New Zealand are converting to it's called Badgernet. It's a computerized nationwide facility for collecting maternity data. It's an incredibly exhaustive computer data set. And having used it myself for several months, there is much detailed information that's all available through other channels. And I don't think general practitioners should be expected to trawl through that to find exactly what happened at the birth. I think, similar to what Melissa said, the key is to listen to the woman's story. having asked your screening questions. Particular relevance is how they affect her, the symptoms that meaningfully affect her, her life, and put that through on your referral so that they can be targeted as best ways forward. I'm really pleased to know that the claim can be tested beyond 1 year for maternal injuries. You'll note things like prolapse may be 2, 4, 6 years down the track, and that's important for people as they get past their childbearing years and beyond. And that's what I mostly wanted to say in terms of Alan's questions about surgeries getting, shall we say, pushed through to the private system. That's a workforce agenda for the College of Obstetricians and Gynecologists to deal with. My colleague Jackie Smaldridge is looking into registrars in the public system being allowed into private surgeries and learning through surgical logbooks. This will no doubt create a large amount of surgical workload in the future when people unable to be managed by physiotherapy are eventually funneled through for pelvic floor surgery. So I can update Helen to say Auckland is much the same as Christchurch. There is a fear or an idea that surgery is going to private may limit public training, but the College of O&G has this in mind, and I'm sure is making steps to prevent a whole bunch of people not being trained to meet the inevitable demand in the future. And I'm happy to take any questions in the chat box. Thank you for listening. Cheers, Sean.
Thanks, Nick. And thanks everyone for their time in that expert advisory group. I think it's been one of the best advisory groups that I've been involved in, and I've been involved in quite a few at ACC. Just their willingness to sort of work with ACC to get some real change put in place to assist people. So it's been a real highlight of my working year. I look forward to each of those meetings, and we've got some questions that have come through in the chat already. What I might do is just read a couple of them out, and then if we do have any subsequent questions, people are able to put their hand up and ask them directly, or just add to the chat that's there. So I've got one here around a GP can make a retrospective diagnosis of a tear if they have an issue suggestive of a perineal tear a couple of months down the line. There are rumours that only midwives or at the time of birth it could be claimed. So absolutely, if a person has sustained an injury at any time from the 1st of October going forward, obviously, and you can identify that injury has occurred, then you're able to put in a claim. It doesn't matter if it's at the time and you're present, or if it's down the line, you know, with some time elapsed. If you can identify that an injury has occurred there, then you can send it in to us and we can consider that for a claim. And so that's, I guess, one of the big changes that's come about, and also with ACC's processes, and that's why it was important that I highlighted earlier. If you use the particular read codes on the quick guide, that will add to the, I suppose, the speed at which we're able to stream those claims to the right place, and get them through our internal systems as well.
Sean, yes, thanks for jutting in there. And no, anybody who is ACC aligned can make that claim. It's not only a midwife or an obstetrician. So any GP or practice nurse can make that claim. And I would be advocating strongly that the preciseness of that injury doesn't have to be delineated. You have to just tag the strain of the knee or the strain of the shoulder, and the MRI, etc., will delineate for the orthopedic surgeon who receives that as to the merits of what exactly the underlying injury is. But as long as there's some sort of entrance into the ACC portfolio, I think that's all that they have to tag.
Yes, what we've done is we've to try and help that is for each one of those listed injuries, we've tried to find the number of read codes that could tag across to the one injury, just to try and make that easier, and so that it's not one read code to one injury, to try and assist with that.
Thanks, Dilky. Yeah, we just had another one here, and it is a good reminder that we have got nurse practitioners and urgent care invited to this particular webinar. And so yes, GPs we have referenced, but also nurse practitioners and practice nurses can lodge claims as well for maternal birth injuries, as can midwives and physiotherapists, which is really great, and obviously specialist obstetrician gynecologists. So I think a really good coverage for our clients across those groups. If people are presenting, then obviously we can help meet those needs through a claim lodged for them. We've got a question here again. This one is looking at, hello, are pessaries covered under this legislation? And I suppose an easy way to answer that is that this legislation is looking at what ACC is able to cover, and that's of course the injury, and when we look at treatment for people who have injuries, it's necessary and appropriate treatment, and that could be treatment from a treating practitioner, or it could be the provision of aids and support such as pessaries as well. So if people are in need of those, then obviously directing them to the appropriate person to prescribe them, and then contacting ACC, and we'll be able to help support the client to get funding for those if they're deemed a necessary part of the treatment that they require. So that's that one there.
And I can take the next one. I've read it while you were speaking. Got a question here about, I guess, if it's a treatment injury. So absolutely, someone said, suggesting that ACC is in fact the appropriate place for people to take their concerns about the care where the treatment was possibly substandard. So absolutely, if it's about the potential for a treatment injury, then as prior to the maternal birth injuries legislation change, a conversation with a clinician and then the submission of a treatment injury claim, absolutely, that remains a vehicle as it always was. I guess we're just making the point about the HDC role compared to ours. Nothing has changed really with the change in legislation. So what you may have previously gone down that route with, continue to do so. If in fact it might be a treatment injury, it is about inappropriate care, and Pete's put his hand up as our local ACC expert on the topic of treatment injuries. So I'll hand over, but yeah, it's the avenues haven't changed. Pete.
Yes, so the key part of treatment injury is really, first of all, has there been a treatment by a registered health professional, and if there has been a treatment, has it caused a physical injury? And then if it has caused a physical injury, then there are a number of different exclusionary criteria. The second half of treatment injury is failure to treat in a timely manner, or a departure from standard. Now, in those situations, if there's an alleged failure to treat, or failure to treat in a timely manner, or departure from standard, we look at where that allegation of failure or departure has occurred at, and we go to an external person of the same discipline, and they're called our external clinical advisors, and we ask them, has there been a treatment or a failure to treat or departure from standard where the clinician could and should have done something differently that would have changed the clinical outcome? And so that's the process of failure, just so you're aware. That hasn't changed through that. And so when we see some injuries in relation to, say, neonatal encephalopathy or other conditions like that, where there's an alleged failure in the process or departure from standard and the standard of care through the delivery or antenatal care, then that's how we might go about unpicking that process. But that hasn't changed. The maternal birth injuries has turned up as a new process. Back to you, Sean.
Thanks, Peter. I think it looks like that all the questions in the chat have been answered. Is there anyone else that had anything that they wish to ask while we have both the ACC personnel and the panel members here on the call. I suppose in the intervening time, is there any other comments that any of the panel members wish to set out to the audience while we have them? Guess I've got one thing I might just pop in at the moment, and part of the expert reference group just before the change went live, Dr. Bev Lawton, or Professor Bev Lawton, who is on our panel, put to the group what we would like to see change as a result of ACC covering maternal birth injuries. She wanted to know the impact that we would like to see. And I guess for me, it was the fact that at the present time we have people who have difficulty telling their story and have accessing care that they potentially need to sort of get back to their normal day-to-day living, or as best they can. And so I guess for me, and the change that's been made, what I'd like to see is that people who have these injuries do start to have those conversations with you, their primary care practitioners, so that they can get a improvement made in the quality of life that they lead. And those things that Melissa highlighted are injuries that are treatable, actually treated, and the help they need. And so I think it's a really big thing that's happened as far as the change to the legislation for those people who are able to get covered under the change from the 1st of October. And I think we will see, quite a marked difference, or I hope there will be, in the provision of care and what people do receive as we go forward with ACC being involved in this. So I think it's a really exciting change that's occurred. It's the biggest change to our legislation that we've had in the last 20 odd years. And I think a really positive one at that. So I think, yeah, welcome, and it's really welcome and a great challenge to all of us and the care that we provide to our clients to make sure that the difference that the Minister intended after hearing the submissions through to her and her colleagues around these particular issues, really see a difference being made as we move forward. So I'd like to thank you all for your part in that change that we will see occur. I just got one more question that popped up into the chat.
I can take it, Sean.
Yeah.
So to clarify, no, a claim does not have to be made within a year. Obviously, a lot of them are made at the time and reasonably soon after, but no, it does not. The one proviso is that birth has to occur on or after the 1st of October. That's the one proviso.
Can I add to that? A lot of these consequential injuries, for example, prolapse, may not appear for 30 years. So as long as, I know I'm encouraging all my birthing parents to hold on to their delivery notes because we only legally have to keep them for 10 years. So let's get those delivery notes to make sure you remember that you had a 3rd degree tear or that you had a 2nd degree tear or something. So I am encouraging my ladies to hold on to their, put it in the cloud, hold on to it. Just make sure that by the time you hit menopause, that if you do develop prolapses and we can relate it to the birthing injuries, you've got those notes.
And then it hasn't, you reminded me, Melissa, it hasn't come up in the questions, but certainly it's been part of discussions in the past about levator ani avulsion and the time to diagnose to that. And one of the panelists can talk to this far more eloquently than I can, but almost by definition, if I've learned anything from listening to you all in the last few months, almost by definition, it will be a slightly later diagnosis. So if any of you want to comment on that.
It was something that came up at our last expert advisory group, Dilke, and I think the one thing that was highlighted at that meeting was the availability of pelvic ultrasound and also MRI for diagnosis. And one of the things that was highlighted was that we will accept claims for levator ani avulsion based upon clinical assessment if that is possible at the time, and only require, I suppose, radiology as part of any sort of down the line planning for clinical care if it's needed, or if it is needed for diagnostics, then that is appropriate. I guess the other thing was the highlight that ultrasound was a very scarce resource from a pelvic specialist or pelvic ultrasound specialist point of view, and therefore potentially it is easier and quicker to get MRIs done for those injuries, and so that would require a specialist referral at the moment.
The big thing was minimum of 6 to 12 months at the earliest for referral for imaging. Clinical diagnosis with digital palpation can be done prior, but the ultrasound or the MRI is 6 to 12 months at the earliest if there's going to be effect on the clinical management, for example, if surgery is involved, but it wouldn't be used, I'm assuming, that early, Nick. Yeah.
Sean, I'm not sure if you've seen there's another question or is it a comment?
Yeah, GPs may not be aware that ACC will fund surrogate births where injuries or treatment injuries do not allow for a woman to have the children she wanted herself. I am actually not able to comment on that one because I haven't looked at a comment such as that before, or have been asked that question before. So I think that might be one that we should take away, and we could potentially post a answer to that one back to the attendees. And we've got another one that's come up. It says, what about mums who have birth prior to the 1st of October with injuries that are then worsened or repeated with subsequent births after October 2022? Would they need to have one of those injuries on the list on their most recent birth, or is worsening prolapse still covered? I suppose this is a great one, I think, for yourself, Dilke, and Dr. Peter Burt. We spoke about this one prior to the session.
Yeah. I'll make a start and then Pete can pick it up. This is going to be tricky, but in some way it is not dissimilar to even sort of physical injury claims that ACC sees currently, where what we have to tease out is the level of contribution of the prior to 1 October condition compared to whatever happened at the birth on or after 1 October. So it is in some ways similar to what we currently face, but we do accept it is going to be tricky. And I think the phrase I've heard Pete uses, it's material contribution, isn't it, Pete? I'll let you take over from this point.
You've summarized it pretty well. So we would usually, when we have that type of request, we would typically go to an external expert and ask them that. And what we're looking to understand is whether whether there has been a material contribution to a pre-existing problem that, were it not for the birth, they wouldn't have had that worsening. Yeah.
So I think it's probably really important to just at this stage outline that for those injuries on the list, if they occur, they're most likely to occur at the time of birth. But for some of the consequential injuries will be captured by this question here. And I think that's when we're looking at prolapses and things down the line, they're the ones that are going to take a little bit more consideration. And I suppose we will see how that goes. I suppose quite some way down the track. I don't think we're going to be expecting many of these cases at the moment, given the changes just occurred. But as time goes on, I think we will see more of these presenting, and it would be great to, I guess, sort of retouch on this later on once we've got a little bit of, I suppose, experience under our belt. All right, well, I think coming up on time, so it might be a good time to close things off. I don't think there's any other questions that have come through in the chat at the moment. If you do have a question, I'm just going to share my screen again just for those contact details for ACC. So if you do have a question, check the ACC Health Provider Helpline, Engagement Performance Managers, our website, so both for health professionals and birthing parents. There is a one here Marie had asked me to plug, which was we'd love your feedback. If you do have any feedback you would like to provide to us, this email address down in the bottom right corner, maternalbirthinjuries@acc.co.nz, will come through to my project team, and we will be able to direct that around the organisation to the best person to answer it, or to receive that feedback as well. So I guess I'd like to thank everyone for their time tonight, especially my colleagues who have given up their evening and the expert advisory group members who have given up their time to come along and support us with this particular webinar. And just to finally close with the ACC Karakia again. So whaia, whaia, whaia te tika, whaia te pono, whaia te araha. Mo te oranga tangata kia puta ki te whaia au ki te o marama. Haumi e, hui e, tai ki e.